Hi everyone, welcome to BioGenie, a podcast where science meets everyday life. My guest today is Dr. Prashant Chhajed, a pulmonologist who's been specializing in this career since the last 3 decades. So, Doctor, welcome to the podcast. Thank you so much for coming here, and let's dive in today.
Thank you for having me. Yes.
Yeah. So, Doctor, what first drew you to pulmonology and specifically tuberculosis and chest disease? Was there a defining moment in your career?
So, pulmonology as a field was not so well established.
Okay.
When I finished my internship. So during my internship, we do a clinical year in various specialties. Is there medicine, there is surgery, there's gynec, ENT, ophthalm, all the branches of medicine. We spend 1 year in the doing clinical work.
Okay.
So, as far as medicine is concerned, there is something called as internal medicine or general medicine. So people after their MBBS can go and do general medicine, and then after general medicine, you can do further subspecialization into cardiology, neurology, endocrinology, whatever.
Okay.
Now, respiratory medicine at that time was clubbed with TB, so it was called MD in TB and chest diseases.
Okay.
So the roots are back to tuberculosis, where tuberculosis has been a major issue in our country for last several decades.
Yeah.
So the government always wanted to focus on tuberculosis. So most of the pulmonary work that was happening, most of the pulmonologists were dominantly treating tuberculosis, and that's how the degree MD, TB, and chest came up.
Okay.
That has eventually evolved into MD in respiratory medicine or a DNB in respiratory medicine. Okay, that's how the evolution happened. So at that point, during my internship, I was very attracted towards tuberculosis. I had a lot of questions as far as pulmonology were concerned. I had been at some conferences where I could see that there were foreign speakers, and they were specialized in respiratory medicine. And they were talking not only of tuberculosis, but they were talking about diseases other than tuberculosis also.
Okay.
Okay, like asthma, there's lung fibrosis, there is bronchoscopy, etc. So therefore, internally, I thought, yes, if I get a chance, I should do pulmonary medicine.
Oh, so that was a very upcoming field when you
Upcoming
started.
field that time,
Okay.
yes.
That's very motivating. So, we all know smoking is bad, but what's one more thing that people don't know about that might damage your lungs equally?
So smoking. So the question is, what are the things which are similar to smoking, or
Yeah.
which can do harm to an individual, which is similar to smoking? So there are plenty. So let's restrict ourselves to the lung at the moment. So in lung, pollution is as good as bad as smoking. Pollution, air pollution, or you know. Uh, let's keep it at air pollution right now. That can the components of air pollution can be so harmful that it can not only affect your lungs, but it can also trigger an inflammation in the body and affect various organs. It is linked to heart disease, it is linked to stroke, it is linked to hypertension. Okay. It is also linked to cancers. So if you ask me, something which people know, pollution is not good, but pollution can be responsible for so many things. And of course, as smoking is linked to COPD and to lung cancer, similarly, pollution is linked to cancers and can also be linked to chronic obstructive pulmonary disease or COPD.
Okay. So, I think that's something that all of us should note. This is still a major public health issue in India despite so many decades of awareness. So, from your perspective, what are the main challenges that keep TB so persistent, and what's finally some new methods that are starting to work against it?
So TB is a contagious disease. So pulmonary tuberculosis particularly. So when an individual coughs, it spreads from one individual to the other individual.
Contagious.
It's contagious.
Yeah.
And there are various factors which have been responsible for the high prevalence and incidence of tuberculosis across the world, including India. Which were those factors? Factors were, not adequate nutrition, crowding, not adequate focus from the healthcare perspective, delayed diagnosis,
Yeah.
and then not having adequate therapies. And then, one more problem with tuberculosis is, if somebody gets an infection like like a throat infection or a pneumonia infection or a stomach infection, people are normally given antibiotics which can be anywhere between 5 days, 10 days, max 2 weeks.
Okay.
Here the treatment goes on for 6 months to 9 months, sometimes longer also. And if there is no compliance with the treatment, that means if people don't take the treatment properly, then there is a risk of drug resistance. That means the same medication which you are taking to treat tuberculosis will not act against the TB bacilli, and that leads to an emergence of resistance. And this is exactly what has happened. There has, for various reasons, uh, tuberculosis has continued to be a problem in some of countries like India. In the Western world, there was a lot of focus on these aspects which I said, and therefore they've been many countries have been able to make a good control on tuberculosis. But in India, these were the factors which presented as challenges. Then the other issue in the past were availability of medicines. So now what the government has done is really, they've taken it up as a very important task. It's a big mission of the government to eradicate tuberculosis. So what are the things the government has done over the last few years? Government has made TB treatment free to everybody. So everybody should know that tuberculosis treatment is available free. I mentioned to you about the diagnostic problem about tuberculosis.
Yeah.
So now there is a molecular test which gives you a rapid diagnosis of tuberculosis. That's called as the CBNAT or the TB gene expert. The government has made that also free in through various outlets. So this has enhanced the diagnosis of tuberculosis and the treatment of tuberculosis by making it available. Now, the other important thing is the government has a follow-up SOP. That means once the individuals are initial therapy, they are now tracked to make sure that they are taking treatment so that there are no lapses in the treatment. People are not giving the treatment halfway through. Now, if you see, there are various, India's a large country, there are different, classes of people. Some people may want to go to the government setup, some people may not want to go to the government setup for treatment. So now the government has partnered with private practitioners also. For example, like us, patients can come, we've partnered with them. So if that sputum test has to be done, we can collect it at our center, and then the government will take it and then make a diagnosis. So the patient doesn't have to go to a particular center. So patient can give a sample here. If somebody has to be initiated on treatment, then we can initiate the treatment here. There's a particular form we use, and with that form, the patient can go to the nearby chemist, which have been appointed, and they get medicines free. So I think these are very fundamentally strong measures which have been taken. One of the problems in India has been over the last few decades is the emergence of drug resistance. So we had the problem of the patients not having compliance with treatment, not adequate treatment available, XYZ, and somehow multiple factors have led to drug resistance. It's not unique to India, but it's they're all across the world. But for India, it's a big problem. And when you talk about drug resistant tuberculosis, that means the routine medications which you're not which you're going to give to the patient will not help the patient to be cured of tuberculosis. Now, TB is in theory a curable disease, and then you have to give different regimens. You have to give more expensive medicines. You have to also give medicines which have potentially more side effects. Okay, so that's the challenge with treatment of drug-resistant TB, or known as a multi-drug resistant TB. So in the past, we would treat that for regimens up to 24 months. Now, in the last few decades, there are new medicines which have come, and now the government has made those almost near patented medications available free of cost to the patients. But then you have to go through the particular government system, and then you can avail the treatment. So I think a lot of such steps, I know we can keep on talking, but the message what you can give to the people is that TB diagnostics are available at free cost. You can get a sputum test done. In many places, you can get an X-ray done without charges. And if you're diagnosed as with tuberculosis, you can get the treatment free.
So it's been made really convenient over the past few
Yes,
years.
yes, it's a government's mission to make India, eradicate TB from India.
Yeah, yes. Focus on sleep disordered breathing and oxygen therapy. So these are areas that many people overlook essentially until something very serious happens to them. So what are early signs that people should watch out when it comes to any oxygen related or lung problem?
So, when we say, if you see, sleep is a broad subject by itself, where the pulmonologist plays a dominant role is in a condition called sleep related breathing disorders.
Okay.
Okay, so sleep breathing disorders, the common ones are obstructive sleep apnea, and then there are other different types of syndromes, including obesity hypoventilation syndrome. So let's focus on this main part. One is, so when we pulmonologists, the focus sleep is mainly on sleep apnea. So what happens in sleep apnea and why pulmonologist is involved is in sleep apnea. Apnea in Greek means stoppage of breathing. So
Okay.
sleep apnea means stoppage of breathing at night.
Okay.
Okay, that's what sleep apnea means. And because there is stoppage of breathing at night or reduced breathing at night, there is a drop in the amount of air which goes in the lung. There's oxygen fluctuation at night, more common in people who are snoring, more common in people who are obese. Of course, it can happen in non-obese people and non-snoring people as well. And that's how the pulmonologist comes into the diagnosis and treatment of this condition called sleep apnea. Now, oxygen therapy again is something that can be given whenever the blood oxygen goes down. There are many reasons for it. You can have a lung problem commonly because of which it goes down, like a pneumonia or a lung fibrosis or an advanced COPD. You can have an acute condition where you're given oxygen in the hospital, and then there are chronic conditions where people will need to be given oxygen at home. So I think these are the typical indications and brief about
Okay.
sleep and oxygen therapy.
So some precautions people should take in just in
So
case.
as far as precautions concerned, I think it's the awareness. The question is, as you said, people are not aware of it.
Yeah.
So what people need to become aware is that, for example, snoring is taken in the stride. Oh, it's normal. Oh, that person having a deep sleep. But snoring with other symptoms such as daytime tiredness, fatigue, forgetfulness, loss of productivity, uncontrolled blood pressure, diabetes, having a stroke, heart problems. In those situations, in any of these conditions, and if you are snoring, I think the people should be aware that they need to be evaluated for sleep apnea. Doesn't mean everybody needs a test for sleep apnea, but you can go to your doctor and discuss about sleep apnea, see whether your symptom profile would take you towards the evaluation of sleep apnea. So again, to simplify it, snoring can be simple snoring, but snoring can become complex when there is a obstructive sleep
So a
apnea.
few things that everyone should always watch out for. Yeah. So interventional pulmonology sounds highly technical. So could you explain what it involves and how it differs from traditional pulmonary care and maybe a case that really shows how it impacted?
So, pulmonology is something related to the lungs.
Yeah.
So, a pulmonologist is a specialist who's a lung specialist or a respiratory physician or a chest physician. So as far as the physician is concerned, we're talking about basic differences between a physician and a surgeon. A surgeon is doing surgeries and operating, etc. And a physician is like the doctor who would examine, diagnose, get tests done, make a diagnosis, treat, monitor you for the treatment, etc. Now, as the field of pulmonology is evolving, uh, things have moved from just blood tests and x-rays, then towards CT scans, and then biopsies and microbiological tests. And as these tests get evolve, an important aspect is acquisition of material for testing.
Yeah.
Okay, say for example, the simplest thing to do to look for lung infection, like for example TB, is you give a sputum sample, you send it for testing, you have a diagnosis of TB, and you start treatment.
Okay.
What if the suspicion of tuberculosis is there? You've done the sputum test, is negative. X-ray shows that it's a possibility of tuberculosis, or the CT scan suggests that there's a possibility of tuberculosis. Patient has symptoms of tuberculosis. How would you prove? Because the days of just treating empirically on clinical basis, you know, are
Yeah.
not the preferred is not the preferred thing in the current modern medicine. In modern medicine, you need to have a as precise diagnosis as possible, and
Yeah.
therefore one could do a bronchoscopy. That's an endoscope which you would pass through the nose or mouth into the lung,
Okay.
go into the area where the problem is depicted on the CT scan, take a sample under vision from there, and
Okay.
send it for testing. So that enhances your diagnostic
Yeah.
yield, and it helps you to make a precise
So you get a
diagnosis.
more detailed view
So
of
it's a
what.
precise diagnosis.
Yeah.
So bronchoscopy is one of them. So once a thing is about just going inside, taking the sputum or some wash from there and sending for testing, there are certain conditions where you need to get a tissue for diagnosis, like a biopsies. We hear this word biopsy quite commonly. So sometimes we need to do a lung biopsy. So for the lung biopsy, also you pass an endoscope into the lung, and then you take a biopsy, and then that helps you to make a diagnosis.
Okay.
Sometimes, there are lymph nodes within the chest. Okay, now lymph node within the chest, in the past, they would do a surgery to access the lymph node and take a sample. Then sometimes you can do a CT guided, you could put a needle through the chest and take a sample, but that may not be possible always. So that's where again a special type of bronchoscopy called as a bronchoscopic ultrasound comes into picture, where you pass a bronchoscope, which is an ultrasound at its tip. You put it into the airway, you do a scan like you do an ultrasound from outside, you do an ultrasound inside, you locate the lymph nodes which are enlarged, and you take a sample under precision. So you can make better diagnostics. So procedures such as a bronchoscopy, lung biopsy, then you have EBUS, then sometimes you may need to do, treat airway strictures, airway cancers, etc. Then you move to rigid bronchoscopy. So these procedures which are performed, and these are pulmonary interventions. That means you've gone a step ahead of your daily physical physician practice, and you're doing interventional procedures, and that's what interventional pulmonology is about.
Okay.
It's like cardiology. You go to a cardiologist, he would do an ECG, he would do a 2D echo, he may do a stress test, he will make an assessment. If there's blood pressure, etc., he would treat it. But if somebody has a heart problem where you need to do an angiography, you need to put a stent in, that's where the interventional cardiologist comes into the picture.
So it's a more specialized version of.
Yeah, where you're doing interventions, you're doing
Yeah.
procedures. So physicians plus procedure is equal to interventional physician. So
Okay.
that could be a interventional pulmonologist, it could be an interventional cardiologist, or it could be an interventional neurologist for that matter.
Okay, I think that's something really eye-opening. Not sure many people know about that. So you've published over 110 scientific papers. That is extraordinary. That's serious research footprints. So how do you choose which questions to investigate, and how do you bring that research mindset to your daily work life?
So the research mindset started when during my MD days, when I was doing my thesis. For MD you have to do a thesis, you have to do a research project,
Yeah.
and there are very interesting findings which came in my research project, and it was linked to lung cancer. And it was just something simple that, there was a particular type of cancer called as a squamous cell carcinoma, which is most common. Um, Cancers were most common in males. I'm talking about 1996, 95, 96. That's what I'm talking about. And then I collected data of all these patients at Sion Hospital, and there were some striking findings which came. And the findings came that in my research cohort, um, there was a high incidence of cancer in women. the most common cancer was not something called squamous carcinoma, but adenocarcinoma.
Okay.
And also, the cancers were common in women who were non-smokers.
Okay.
So then that was really striking for me. And then I delved more into it, found that the Western literature we don't concur with the Western literature on that point. So that paper said that yes, adenocarcinoma is the most common, and these two or three other points. And then we wanted to publish it because if we don't publish it, then people don't know about it. And
Yeah.
that's how the journey started. And if you see, it's interesting to observe that over the last 3 decades, today adenocarcinoma is the most common cancer uh, almost worldwide, I would say. It's also increasing incidence of adenocarcinoma in women, also in non-smoking women. So this trend was already picked up earlier, almost 3 decades ago.
Okay.
So this is how the interest came. I mean, this is how you can contribute. So on one hand, you do as a clinician, you diagnose, treat, and cure patients.
Yeah.
But then on the other side, we need to learn from that. So the learning has to happen, and the learning,
Right.
there are two ways you can do it. Over a period of years, you have a physician who has got 2 decades, 3 decades of experience, and you say, okay, this is an experienced clinician, fine. Then you go by your experience. But I believe that, I think that's great. We need experienced physicians or clinicians in the community, no doubt about it. But some percentage has to collect this data objectively. You need to analyze the data objectively. You need to contribute to science just so that we can eventually we learn from it and we diagnose and treat better. So I think that's the way science goes forward. So after having done that, then I was in Australia for a few years. And in Australia, when I went there, again, the similar. So the habit of looking, yeah, I was working at high volume centers like St. Vincent's Hospital in Sydney, which is one of the largest referral hospitals, quaternary care for thoracic medicine, lung transplantation, and large volume work. And again, the point was we started to find certain patterns, and then you say, okay, how does this pattern impact clinical practice? And then he said, yes. So if the patient comes to us, we discuss, and we know how this experience will help our patients.
Yeah.
The question is, how do we roll it out in larger way? So if you want to roll it out in a larger way, you need to do it systematically. You need to get peer-reviewed, published, and then more people and the community is aware of it. So the benefit of that research can, you know, be expanded to a larger number of patients. So this is how it happened. And then we moved to Japan. We developed this Ebuscope. Then from there we moved to Switzerland, and then this continued.
Okay. So at some level,
Curiosity is required, and yes, so whenever you're doing the clinical work, you're treating the patient, there are some gaps, there are some questions which are not answered, and then you try to see, in my practice, am I able to find something or which can help to take the science a step forward. And we continue that also after coming here. So we have the Institute of Pulmonology, Medical Research Development. So here also, after coming to India, also we've continued to publish as best as we can.
Okay, that is extremely inspiring. It's a wonderful thing. So COVID-19 put an enormous spotlight on respiratory health, and how has it changed the way both doctors and patients approach lung care today?
So, of course, COVID-19 was not good.
Yeah.
But then your question is about how it has impacted um, doctors and patients. So, as we discussed earlier, I took up pulmonary medicine just at the point when it was, I would say, evolving, the awareness was increasing, and a lot of work needed to be done
Okay.
to establish itself as a specialty. Of course, that evolution happened, and still, the awareness of pulmonary medicine as a specialty was not deep enough. And the reason are fair. I mean, uh, the symptoms or the patients or the diseases which are treated by pulmonologists are treated by many by the those are the symptoms like cough, breathlessness, lung infections, pneumonia, fever. A general practitioner could treat that. A physician, an internal medicine physician can treat it.
Yeah.
Okay, and a pulmonologist can treat it. So there was always these things, that for the last years it's been treated by the physician, and the physician would refer to the pulmonologist if there are problems, and which is fair. But what happened after COVID-19 is that the role of the pulmonologist got a better audience. People got a better understanding that the specialty exists, because there are certain things. It's all about focus. We need good physicians. Yeah, so don't get me wrong on that. We
Yeah.
need good family doctors. Don't get me wrong on that as well. But then there is something. Cardiology can be treated by family doctors, by physicians, and then you've got specialists.
Yeah.
Okay, so everybody has a role to play. So the role of the pulmonologist was getting slowly established, and what COVID-19 did is it really increased the awareness, and I think establishment of pulmonary medicine as a specialty in a stronger way. So that's for the doctor to happen. As far as the patient is concerned, now the patient, so pulmonary medicine or any specialty can get established not only by the doctor claiming, oh, it's a specialty. The patients have to accept it also. So the patients have also started to accept, understand that if there are some pulmonary problems, the routine stuff gets treated at the local level by your, whatever your initial points of contact are. But if issues are not getting solved, you need there is a specialty of pulmonary medicine available, and one can resort to it to get better diagnostics and better treatment.
All right. Okay, so something informative that I think everyone should note. So you hold fellowships and leadership roles in both Indian and international bronchology association. So how do you guys collaborate and help countries overcome the problems?
So again, you have a clinician, you have a clinical researcher who does clinical work and research, and then you need to publish that. And once you start publishing, you realize that yeah, once it's documented on paper, it still needs to be spread around. And then that's when you start getting invited to speak, you go to conferences or meetings, you're invited. Okay. Now, who does the invitations? Again, a majority of them are by congresses, by conferences. And then who organizes the conferences? They are arranged by the societies, majority of them.
Okay.
And that's how so it's a journey. So as you move up into that journey, and then of course it's not necessary everybody wants to take that additional work of being in the association, organizing meetings, taking decisions, giving lobbying, doing guidelines work, taking leadership roles. Not everybody has to do it, but then if somebody has an opportunity and inclination, I think some of us do it. And I started that already when I was in Europe. So I was, as you may be aware, you must have read, I was secretary for the for the European Association for International Pulmonology. We did that. Then I came back to India, and from India also, of course, my interest was there because we wanted to contribute towards academics from a society perspective where you need to be involved. And then I could get elected as the initially secretary for international pulmonology vertical at the European Respiratory Society. That was 3 years. So we ran the office from here for that. And then after that, I was elected as a chair for the next 3 years. So again, all these positions allowed me to contribute academically towards the cause of science. And the European Respiratory Society is the largest respiratory society in the world at present.
Okay, that's brilliant. So
After coming from that, again, of course, I've been all the Indian societies as well. I was the West Zone Chairman for Indian Chess Society for 4 years, governing body members, etc. What do you do in this? You would go then, you would help to organize meetings, you discuss about scientific contents, you discuss about what should be the pathways, are there some guidelines to be made, so all that sort of work.
okay. So lastly, with all the increasing pollution in the city, what are some tips or advices you give to people to stay safe and take care of the lungs?
So I think again this is the last topic, but I'll sum up. I'll give you a summary. So we know that of late also the pollution and the smog has been increasing, even in the city of Mumbai. And I think the important thing one needs to understand is in winters, if the wind is not moving very fast, if the humidity is decreasing, then if the temperatures are low, then the pollutant particles hang around in the atmosphere at a lower level.
Okay.
Okay, so as the temperature will increase, as the sun comes out, as the temperature increases, these pollutants will go up. So the message for the morning walkers, and as I've put on other media resources as well, is that don't go for a morning walk until the sun is out.
Okay.
Okay, that's very important. If somebody who has an underlying lung disease like an asthma or a COPD, you must continue to take the medicines regularly as advised by your doctor.
Yeah.
On the days when the AQ is very high, you should try to stay indoors, particularly for people with advanced respiratory disease or those who are elderly. And if you're forced to go out because you may need to do something, you may be forced. In that case, you should use a good quality mask and step out. So for people with lung problems, on medication, sensitive to the pollution, an N95 mask is what would be recommended.
Okay.
Now, and then there are other things, you need to people talk about air purifiers, etc. For
Right.
those who are in an area where your home is very close to the street, or there's too much pollution, and this individual is unwell and going to stay most time at home. In that case, there may be a role for these air purifiers. Having said that, the role of air purifiers eventually still under evaluation. There are some data which say that there may be a benefit, but the air purifier would be restricted to a particular area.
Yeah.
So a lot of things need to be studied before large recommendations can be made
Yeah.
for that. So at the moment we keep it very restrictive and very specific.
Okay.
Yeah, because it also comes with a cost.
Yeah. True. So, doctor, thank you so much for this. It's been a very insightful conversation, something I learned a lot, and I think the viewers also learned a lot. And yeah, to those watching, remember, bio isn't just a subject for scientists, doctors, or lab assistants, it's for everyday people. You can also utilize it in your everyday life. So, if you enjoyed today's podcast, check out the rest of my episodes. Stay tuned, and thank you so much. And thank you, doctor.
Thank you.